Hi, I'm Sérgio Mota. I'd like to thank the organizing committee of this event for my invitation. I hope share with you some of my experience using this type of the homologous bond grafts. And and when I talk about my theme, um, the about this graft, homologous graft. We needed to explain to you about this kind of procedures. In the Brazil, we don't have statistics, but in the United States you have, and for more than 2 million procedures happen in the last year. And when then think about the grafted, we have the goal is you using the biomaterial or using the autogenous or using the homologous bond and this grafted you integration and supporting the tissues around the implants or and different kind of your body. You can give it support to the statics and biomechanics. This is the goal. When you see these pictures and the patient, you have two different graphs and two moments in the past and the present. You see in the graph that did in the 28, and you can see the white and the arrow, and he's still there, no integration, no working with the graft. Um, then the function to this graft it's bad. And I see another one, and the homologous bond fixed in 2023, and these procedures try to fix the problem that happened in the lost bone around the implants. You can see them the both. Then when I talk about this, you need to back in the past and remember the guys who give support and to implantology today. It's Brennemark and Schroeder and Straumann. And they support with osseointegration and functional class. And your procedures step by step, it's begin to easy to use an implant osseointegration now, today. Then, in my case, I begin to use this kind of implants, but not really these pictures. It's different. It's this implant is today, but it's the principle. It's easy. It's the same. The body has 3.75 millimeters, and the neck um, um, 4.1. This is the principle. Then Randy Marker give this support, and then he's and in the past he's understand um, what happened when remove tooths. Can see them, and they have different moments with the tooth with the teeth. Remove the teeth immediately. Some teeth removed and totally dent. Can see that. And his your techniques begin your papers. It's introducing plants between mental forum and support and the fixed bridge. This is the goal. The goal is this one. When they see these pictures and occlusal view, you see your implant protected, inserted totally in the basic bone. You don't have alveolus bone here, only basic bone. Then the possibility the implant it's work well because it's protected to the bone, integration to the bone, it's height then. Um, this way you begin to understand the success these implants. You put these implants in the mandible, and then 4, 5, 6 implants in basic bone, and made the bar and with the static composites considered, and then consequently it's this way. You see this condition, and this condition, it's nice for the mandibular. And when they look this mandibular in that also considered way, and begin to understand when have tooths and the alveolus bone, remove the tooths, you begin to see the middle, the pictures in the middle with the porous, but and you see the windows in the open to see the quality of the graft, this medullary bone and a thick cortical bone, and the last one, the right, without any kind of the alveolus bone, you begin to understand well what happened and why it's using this implant. You have a high success, 95% in mandibular. And they'll see this piece, anatomic piece, can see this one. And you can understand this, why using this mandibular a bit more supported, because they have a height and then quantity of the bone and no accidents anatomically in this, and you can give the end trouble. Different maxilla, you have this sinus closed, nausea closed, and then it's the bone is short and difficult to support and prosthesis. Then it is need to focus about this, and you can see this the height this the implant you can introduce and support and the bridge. It's interesting to view. Then continue to see, understand why this using the graft is in this in the past, and you see this the view the developed line based on the Monson Terrier and the Boeing triangle, the Boeing. You can see this here, the line passing in the cuspids, and then understand the direction have the observation this the bone and the height of the bone and the posterior mandibular different in the mandibular and the anterior mandibular. Then when you introduce the implants in this the area immediately low, those remove the tooths and put in implants and immediate implants, sorry, and when the support and the alveolus bone, it's this alveolus bone only exists when it exists teeth. Então, possibly you lost your bone and exposing the implant, its height different than we put implants in the mandibular this way. You can see this way, yes, and then you are no more alveolus bone. You can see this. Then you continue to review, understand that the maxillar, and this maxillar, you lost a lot of bone and the wide and the height. Then you can see different moment with the tooths and remove the tooth, or partially remove the tooths, and with a dentalist condition, and they understand introducing implant here, you can see this way, and it's difficult to understand the ring. It's implant protected to the bone, and the red it's implant no supporter bone, don't involve it to the bone. Then because you have observation this bone, this can see. Then if you begin to understand why the past using this kind of implant thin, it's conventional implants, and then maxillary don't have support, and uh, to the implants with the format it's the screw, and then you can see this implant is it's very difficult to make prosthesis and the statics and biomechanic, and the clean is very difficult to in the past, and today it's the same. Then you can use in different procedures, but to fix this conventional implant, but you need to remember the goal is to the company. You put implants, cylindrical implants in the mandible and the maxillary. And this way you can sell a lot of the implants, and it can be supported to the prosthesis. It's easy to make the prosthesis, and they have the protocol to do. And then you remember again this the mandibular, this case, the implant is totally protected to this the bone different this condition. Then the company simulation research about to put implants and in condition to support and the process. You can see the implant is it's in the sorry, put implants in the middle of the bone, the maxilla, and the name is approach palatal, and then and the support the bridge. You can see this way. This technique is one put this way. You can see this both sides, and the support the bridge, the metalloplastic bridge. The problem is that this technique is the patient. It's difficult to speed and deglutition since very to eating, and then sometimes you need to remove and back to this to dentistry again because patient don't like this, don't feel well, and it's different. Then really you need the 6 millimeters to inside this implant with the base of the brand mark implants, the 4.1 the neck and 3.75 and the body. You can see them. Then what company did in the past support and research about the grafts. The goal is you put the grafts and inside prop implants to condition to support the bridge, support the process in this case. Then this result coming to using autogenous bone, intraoral autogenous bone. You can do it in the offices, in no necessary to come into the hospital, and then remove the bone to graft the maxilla, then see this the both. The problem is when you use autogenous, you lost a lot of bone, and in some case, it's different. Then continue to research, you understand the difference, the quality of this the medullary and cortical bone and big cortical bone around. Begin to understand well the bone is where you are when it's the way it's working in the mouth can continue to see the same. Then when you have intraoral bone, you come to extraoral bone and the iliac, this tibia, this ribs and the cranial, and then you can see this case. This patient didn't have this intraoral bone and using iliac bone. You can see this the grafts and the fixed implant. You can see the way and then metal ceramic probe. But when you using this autogenous bone, the problems starters, and you can see the result to the papers a lot of problems with this pain, blood and paresthesia, and that give it coming to the patient to the hospital, exposure anesthesia. It's the problem. It's between 25 and 47% this case have some kind of the problem. Then for me, I begin to think out, I don't need it. I don't think it's good. You can see this broken, the mandible, the patient removed the retromolar, hematoma and paresthesia with infravertebral supply. And then you can see this emoji in the posterior area and blood a lot. Then you begin to looking for a new procedures with the biomaterial and techniques is support, and then with the we see this homologous bone and use more than 100 years, and then oncological and then trauma condition, and the use to this biomaterial can see that's the same. This you have a lot of research about this. Then you give a new view, and the problems is begin to last. Then I can see this. Then you see this case, the patient coming with the prosthesis, both prostheses is your smile and your condition, the static condition, and remove it, then it's terrible. And this lady is, it's young lady, it's 7 years old, then you need to, no bone, no intraoral bone to remove. Then the patient told, I need to come into hospital, remove your ribs, or you can use the bank band. And then why? But you are safe and it's nice. And in this case, you made first the sinus lifted both sides because the bone, homologous bone needed to have a contact and with this bone, and you have the vascularization. You can see the holes in this to have a blood coming inside the graft. You can see this, and need to be fixed. And in the past, we begin to listen to my colleagues and the patient. It's safer. It's safer. This procedure is safer. This biomaterial, you can receive it and material. The guy is die. You can see this the piece of the bone removed to check with the histological, and it's important to me to check the histological numbers about this grafts. And you see this CT and introduce the implants. You see the X-ray, panoramic X-ray. You can see this fixing the maxilla and put implants in mandibular to brain mark protocol. Then see, and the histological view, I can see this osteoblastic condition, new bone formation, and no inflammation in the patient. It's nice. It's very interesting. And 4 months later, I put this open again, and you see this the modeling the bone because patient using dentary, and it is a big problem when you have the patient a dental patient maxilla and told to him, you didn't using the dentary because you using the shanogial membrane, and in this case you're in the shanogial graft with membrane. If you have some movement, you lost everything. And this and patient prefer these procedures, can use in this dentary and see this bar and fixing the mouth and the dentaries and the model and your mouth can see the static condition. Then he come into this moment for this, and then she feels very well and can bite and then eating and the speech in excellent condition. You can see this way. Then you come in this case you now understand that you're using the grafts in the dental condition, but the time pass and you can see these pictures about this 996, the first paper published about this single tooth removed the implants, and you'll see this paper 49 single tooth removed and put the implant, and only 33 aesthetic zones. Then the patient, you can put it implants, it's work very well. You can see the data is 19, 95, 20, and then but the static is terrible. But in the past, I can use this. So you can see this condition. Then you begin to understand well the alveolus bone working understand. Then you did this histological analysis and understand this the bone without vascularization, bone with vascularization, the proximal bone, they have a lot of vascularization. And we removed the tooth, removed this fascicular bone, and we lost 1 millimeter the implant. You can see, and you need to remember well this pictures because this view, Araújo, Lynch, and Cadaro begin to understand and put in the literature what happened in the buccal wall. And then when you remove the tooth, you don't need any kind of the procedures to graft. You can see then you lost the buccal wall, the height and the weight. It's happened. Then the company began a stimulation to graft this alveolus, but this chenoidal graft, this allogeneic plastic graft, it's so sensitive, and then you need to have no infection, any kind of infection. You can see the loss of the green, this white in the back, and then you need to cover and protect this membrane. That's a difficult procedure. It's not easy this way. Then really, in the past, I did that some procedures to fill the alveolus and loss, but I begin to coming to use this way. Then I begin to no, it's need to fill the graft to with this alveolus bone because I don't want to lose the bone. Then to insert the implants, you can see this what happened. And you need to close it with this biological procedures and temporary or it's to give the success about in the graft with so allogeneic. In the past, because this begin to fill the alveolus with this autogenous bone, remove the chin and the see and see the view if this insert the prosthesis. And later, 70 years later, you can see the contour and it's maintained. And the 27, you can see this view, the front view. And then 70 years later, you can see the colors different in the area, you know, where it are these implants. Can see them and different the tooths and the quality of the tissues. You need to remember when to do the graft is no more alveolus bone. The graft is a new bone, new kind of the bone integration in the plants. You need to remember well this kind of the bone. It's sensitive. These are biomechanical infection. We need to attention all the time about this. Then the procedure is easy. You can see them remove the tooth, put an implant, fill the gap, and no infection on the gap, and the wall it's need to stay well, the buccal wall needs to stay well, exist then, use it temporary or use some kind of procedure to protect the alveolus, and then this consequent you have this way, but there are prostheses fixing implant and but in the excellent condition with this the tissues, soft tissues and the hard tissues can see them. Then, but when you don't have graft, don't do the sorry, don't did this alveolar grafts. What happened? Really, when we do the research in the school do the statistics about this is 7% only the patient come with buccal wall to introduce implant in good condition. The basic plan is research, and then you can see the defects in patient and lost the bone, lost the tooth, and can see this the left pictures of this something white. It's graft with stenotional condition, and then if this condition is not nice, then you can use in any kind of procedure. In the case, the first it's autogenous, the second it's homologous, in the middle it's homologous one, and you see these procedures later. And you see this it's nice to support implants and then continue to do the rehabilitation with the prosthesis, and the view it's nice. It's the patient all different procedures into the graft. You need to remember you can using the procedures you feel well and feel understand it's easier and it's interesting to the patient. Then I told you in the explanation this I listened to my colleagues told about it. It's safer these procedures, and they don't give any kind of the disease in the patient. And I told in the past to the patient to my colleagues, look, if you need blood, you receptor blood, it's live tissue, and have cells that have a lot of the organic components, and then anyone told it's dangerous. You need them. You need the graft tissue, and but to me, I need to confirm my what I think, and then I think it's if you use any kind of this material, the case is bank bond, this tibia bank bond, and you can see they have different. Sorry, this is tibia bank bond. Another is different origin your body. The guys died, and it's. I think you need to understand what working and what the problem I have this one. Then the homologous bone graft, it's in the bank bone. The first is it's a freeze-dry radiation, and I using this grafts. because with safe because you don't have organic components, then your disease is not happen. It's easy to shape and fix, and then this different this cyanogenal condition because you need to membrane and need to protect it to this movement with the proteins. In this case, you can see this both. Then biocompatibility is very interesting. You can see the biocompatibility in different levels and in different moments within in lab and in vitro, in vivo, and then you need to attention this. Your company give you support into this, understand this condition. The example it's the research with the Oliveira in 22 and did in the hat, and they understand and biocompatibility and the tests happen, and then in the case it's material, and it's nice to me to analyze your histological analysis and give you the score to make this analysis histological. That's very interesting procedure to consider. Then you need to have this biocompatibility in practice, it's safe integration in absence to harmful effects, although immunological problem, inflammatory problem, infection, and carcinogenic problem, and then another toxin reaction. Then you can see this way, and then modeling the graft in the mouth and need to observation what happened with this. I know in the moment this it's interesting to not know past more than 6 months if the patient is. And the histological analysis, it's new. They have a bone new formation, new fermentation, osteoblastic activities, and the graft absorption control. You can see these numbers and can see the score if your histological view, and then this way to begin to do. No, it's nice procedure, nice procedure. Then I come to the case one, and the patient come in 28. You can see this is the moment it's she lost the one tooth, then but you have another one with the implant and your prosthesis. You can see this. In the past, we removed the chin, piece of the chin, and fix in the area. You can see them cover with the biomaterial because I had an experience lost out of my bone, autogenous bone, and cover with the biomaterial. You can see them, and then and see the patient, the occlusal view. You need to remember well these pictures with the quality of the graft. It's solid, you can see them. And see this continue using the guide. It's open the t-shirt 4 months later and introduce the implant, and then can see the view, the position, a special position, and thick the bone protected implant and the suture and the temporary, and see the occlusion moments, and then on the open the second time put the abutment using temporary and using this and the crow with this metalloceramics. The CT, you can see this the graftness and the plant protected to the bone, and you can see this way the static condition. Then it's in 29, and then patient come out, and then back in the 2023 this condition then we stay is living far from my office, the clinical office, and coming using your care with this patient, the professional with but you try to do some procedures, tissue procedures, soft tissue procedure, but you can lose, and then this condition static, this one, and then remove them and told to the lady, I need you back because you lost a lot of bone and implants, and then remove this your implant and do again the graft and do again the implant. You can see this. And the patient's agreement. I remove the implant to retriever with the procedure is more less aggressive as possible. You can see them remove both and one and another, and then you can see this the implant is broken because I removed the retriever, and see the holes on the way for remove the implant, do the sutures, and then you can see the sutures if and weighting the tissues, soft tissues. It's had a good answer, a good position about this, and can do the mensura about this, temporary, and can see the pictures in the moment we did the graft. Do this inverted incision, you can see this way, open the tissue and can see they have this condition. They have a old Histological graft. You can see them. Remember the picture on the past, it's solid graft. You can see no integration, you don't work well. You can see loss in the height. It's very height, lost bone. You can see this way. Then you do the gabarit with the bone, with you made shape the bone, the homologous bone. You can see this clean, and you but protect this alveolus bone and to give it the support and the vascularization, and then and you can see this clean with the burns, and then with the way, and then but this the proximal area it's protected. Sorry, shape this the grafts is homolograph the tibia, can see that, and then cutting, and then um, check in the mouth, you can see, and fix it as well as possible with this screw, and then vascularizate it's closer to the bone. Then this way it's possible to give a new bone formation. You can see this bone is protected then, and this way this papers is this result is here, it's there, and cover with the biomaterial. You can see this quality of the pore. There are pores in the biomaterial. That can be nice to understand. And close with the silk because I like it to. I don't want to open these procedures. And then you can see the smile, this first moment, and then CT with the graft fixed, the integration, and then this waiting 4 months and open again. Remove the screw, remove a piece of the bone to put in the screw with Trofina 3.5, 3.0, and can see the pictures, the occlusal view with this, the guide, implant inserted, and then you can see this, the implants, and then remove, can see the blood come with the tissues, and then remove another and fix another implant, you can see that. And close and waiting 6 days, the case, the teachers put in temporary, and the teachers and can see the CT, the position, the implants, and protected the graft, and the smile of the patient, and the final restoration, you can see that. And the second case, I'm sorry to the fast, but in the time it's short. Patient come with these ones, can see the short, can see the scar in your mandible. You remove it bone with your chin and pass, and this the height, the loss, and you see this the implant, and you are fixing needed and between us and the CT, the buccal bone, it exists in these implants. Then can see the crow and the scare with the tissue, can see this way, and then this is the prosthesis, and then this the height of this tissues, and then the goal is this height. Then see them, and then using the temporary, and you can see the peripheral view, and then sorry, it's important that these pictures can see the curve in the black, and this you see there's no gingival tissue, and you see the vase is mucal condition. Then I remove it with less aggressive procedures, possible retriever, and close at this first moment, waiting 40 days to cicatrization with the temporary, remove the tissues with palatal to get grow condition its the tissues, soft tissues, protected the bones, the sutures, and then you can see this the panoramic view and the scar of this in the one, and view and intraoral view. It's lost a lot in this condition. And then you open inverted incision, you can see this way, and then using the bone tibia, fix, and then you can see the proximal nasal and both sides is a little quantity of this basic bone. Then you can see this way. And the vascularization, these patients for 5 months later, using the Conimoss implant, the platform suite, this the goal. There you can introduce the implant and have the whole to analysis, the histological analysis. You can see this one, and this it's important to us. And then to have the crack with the t-shirts, the way I feel security. Maintain your screw, the the graft, and the implant is inserted, X-ray. This is temporary, you can see this way. And then the histological analysis, you feel osteoblastic and then a new bone formation and no, sorry, no inflammation tissues. And this is a temporary, and you can see this way in the X-ray, the temporary. And this is the tissue and begin. This is the tissue now. It's and remember the gun needs support on the bone and need bond to have a gun. And the temporary condition, and then you can see this the crow it's solid, can see the platform switch and then see this coming this way and this coming this way. And this smile of the patient, it's nice. The patients like it. You need to do the canine again, and then to understand this conclusion, this based literature on research, homologous fusion and utilizado biomaterials appear safe and stable, and we recommend further more studies about this is important to us. Then thank you very much to your attention, and then I hope you give support and your knowledge about the graph. Thank you very much again.